So yeah, so today is a clinical presentation, and okay, so the background of the presentation will be introduction, transmission, and pathogenesis of tuberculosis. What are the clinical aspects? How one can diagnose tuberculosis, treatment of tuberculosis disease, and its prevention. I have specifically left out the treatment of TB infection because it's a new topic which we can discuss at a later stage. So as we all know, the factors that influence any infectious disease, it depends on the host, the agent, and the environment. Now, the triad has to function in unison so that the infection can either be controlled or infection gets aggravated. So the host factors which affect the TB infection are the age, mainly the younger children and the elderly who have low immunity levels are more prone to develop tuberculosis, get infected and develop tuberculosis. Again, the gender also is of importance. Although the male-female ratio in tuberculosis now is around 50-50, and which may change according to the cultural and socio-economic condition of the population. The other host factors are the body defense mechanisms. The cough and sneezing are the local mechanisms. The cellular immunity is the backbone of the host factor for controlling tuberculosis. If the body cell immunity is not good, then there's chances of tuberculosis infection being progressed to active tuberculosis. Antibodies also have a role, but very minor role to play in tuberculosis. Of course, nutritional status affects both the cellular as well as the humoral immunity, and increases the risk of a person developing tuberculosis. Associated illnesses like HIV, diabetes, tobacco smoking, etc., also increase the risk of person acquiring tuberculosis as well as progression of the TB infection to active disease. Some of the environmental factors which play a role are the geographical locations. Certain locations are seen to have less prevalence and incidence of tuberculosis. Climatic conditions also affect the tuberculosis acquisition of infection as well as progression of disease. These are specific, less is known about both these factors, but what is more known is about the sanitation aspect, the ventilation. We all know that the poor ventilation, overcrowded conditions, and poor hygiene affect the TB spread of tuberculosis infection and acquisition of disease. The main factors, of course, the participants are well aware that the agent factors are very important in the tuberculosis. That is pathogenicity of the organism, the virulence of the organism, and the type of the organism, which is either drug susceptible or drug resistant to many drugs. It was formerly thought that multi-drug resistant tuberculosis was less transmissible, but now with the raging DRTB epidemic, we have found that the drug resistant tuberculosis also is easily transmissible. So these are the three factors which have a role to play in TB disease, and control will be prevention and control will also be guided by these issues. Now, as we all know, the causative organism is known as Mycobacterium tuberculosis, which is a slow-growing bacillus, also known as an acid-fast bacillus. It is known as acid-fast bacillus because of its characteristic staining properties, which we normally do by the Zeal-Nielsen stain. The dye gets adsorbed onto the thick mycolic acid cell wall, and even after decolorization with acid and alcohol, the dye remains, and therefore it is seen as these rod-shaped red particles in this smear examination. So that's why it is known as acid-fast bacilli. The MTB is resistant to cold and freezing and desiccation. So it can survive long periods in these conditions and even in dry conditions. But however, it is sensitive to heat, sunlight, and ultraviolet radiation. So even if it is dried and if it is exposed to heat, sunlight, and ultraviolet radiation, the viability is affected and it will become non-infectious. So this is the characteristic of the So anyone wants to raise a point or ask questions, then they are free to do so. Yeah. So this is the characteristic of the Mycobacterium tuberculosis organisms. So moving on to transmission and pathogenesis. It is normally spread by droplet nuclei, and from a person who is infectious, especially with pulmonary tuberculosis, who, when he coughs, sneezes, speaks, or sings, as you saw in the previous slide, the organisms are dissipated in the air, and the normal healthy person inhales these organisms, and these organisms get lodged in the airways and in the lung parenchyma. So who are all at risk? The close contacts are the highest risk of becoming infected, and transmission occurs from a person with infectious TB disease, not a latent infected person. So that's the one thing one has to keep in mind this when we are talking about transmission of tuberculosis. So what is the probability that TB will be transmitted? It depends on the infectiousness of a person with tuberculosis. Now, many a times, the person with lung tuberculosis, when the lesion is not communicating with the airways, he does not throw out these bacilli, and therefore his infectiousness will be less. But if the person has cavitary disease, advanced disease, the sputum will have a lot of bacilli in the and he will be able to spread easily. The environment in which the exposure occurs also is very important, as we've seen the environmental factors like especially ventilation. If a person is exposed to in a very ill ventilated room, or very close to the sitting very close to the person who is infected, then the chances of acquiring infection are high. Even the duration of exposure, it's a 5-minute exposure to a person who is infectious may not infect anyone. But if the exposure duration is high, if the person is living with the person who is suffering from tuberculosis, and then the chances of acquiring infection are high. Also, the virulence of the organism. Now, formerly we thought that the MDR tuberculosis was less virulent, and therefore the chances of transmission was less. But as I mentioned earlier, that it has not made any significant difference whether it is drug susceptible or MDR tuberculosis strain. So that is the role of virulence on the probability of whether TB will be transmitted or not. Now,
I have one question, Dr. Dulkia.
Yeah, sure. Yeah. Tell me.
One is about the latent TB infection, the definition, and the second is infectiousness. How is it measured?
So when we come to the diagnosis, we'll come to the infectiousness of the measure of infectiousness, and about I have a very another slide which will let us know about what the latent tuberculosis is all about, right? Okay, yeah. So that's about that. And pathogenesis, it's a lifetime risk of developing tuberculosis in a person with normal immunity is 10%. So anyone who is infected, if his immune system is good, he does not have any comorbidities or any other risk factors, then there is a 10% chance of that person developing tuberculosis. HIV is the strongest risk factor for development of tuberculosis if infected, and this risk of developing TB disease in HIV infected individuals increases to 7 to 10% each year, as opposed to 10% lifetime risk in a person with normal immunity. If you see, I don't have the figures for diabetes and other factors, but in diabetes, there is a 3 to 4 fold higher risk of developing active tuberculosis if the person is infected. So each year. And then there are other certain medical conditions also which increase the risk that tuberculosis infection will progress to TB disease, such as I already mentioned, HIV infection, substance abuse, of course, it's because of the poor hygiene, poor immunity, poor nutrition. All these factors affect the person, and therefore there's an increased risk of progression to TB disease. A recent infection is likely to progress to active disease. We do not know what is the what you call the pathogenesis of this, but it has been reported. A chest X-ray finding suggestive of previous tuberculosis. So any person who is having previous tuberculosis has an increased risk of developing active tuberculosis from a newly acquired infection. Diabetes mellitus we've already discussed. Silicosis is an occupational hazard, which because it damages the lung, the person can readily acquire infection, and this progresses to active tuberculosis because the local immunity is affected. Also, in silicosis, the chances of, if it is silicosis with tuberculosis, chances of developing lung malignancy is also very high. Prolonged corticosteroid therapy, again, because it reduces the person's immunity, there is a chance of progression of disease, progression to disease in an infected person. Other immunosuppressive therapies like people who are on other immunosuppressive therapy for autoimmune diseases, for renal transplants, other organ transplants, are an increased risk of progression to TB disease. Cancers, hematological and reticuloendothelial diseases, end-stage renal disease, people who have had intestinal surgeries, bypass or gastrectomy. Nowadays, there's a craze for doing bariatric surgery to reduce the obesity. And we find that a lot of these people land up with tuberculosis because of poor nutrition. Then chronic malabsorption syndromes and low body weight, of course, because the overall immunity is low. So 10% of more below the ideal body weight increases the chance of progression to TB disease. So this is a slide which is very busy, but I will spend a lot of time on this. So everyone can see the slide in detail, or I don't think there's any way I can increase the resolution. But if
I
you
think
can,
it's clear. Yeah,
it's clear. Okay, so if you see on the left lower, this is the primary infection. A person gets infected, and the infection comes here. This is the peripheral part of the lung, and the bacilli lodge in the subpleural space, and from there they travel to the local lymph node. So this is in the central part of the chest, and So this infected material, along with the infection in the lymph node, is known as a primary complex. So because of the presence of infection, there is a granuloma formation, and a lot of lymphocytes and eosinophils accumulate over there. There's a lot of giant cells accumulate, and then there's destruction. Because of, I wouldn't like to go into the details of Th1 and Th2 responses, but yeah, so this happens over here, and this is the primary complex. Is usually happens in children, and if the immunity is good, then the organisms are taken care of at the sites, and there will be healed lesions which occur as scars both in the lung periphery and in the lymph nodes over here. So if the organisms are killed, they are not viable anymore, then they leave scars. Now, sometimes because of metabolic peculiarities, the organisms, they are not killed, but they lie dormant, either in the pulmonary or extrapulmonary sites. And these are the lesions which are known as latent lesions. So this is what we label as latent tuberculosis. So this is in case where the immunity is very good or partial good immunity. Now, if the immunity is very poor in a child, then what we get is a progressive primary tuberculosis. Now, just to inform that these lymph nodes are very highly vascular, and the organisms spread via the bloodstream into the whole of the body, right? They can lodge in the brain, they can lodge in the kidneys, they can lodge in the intestines, the periosteum, that is the covering of the bones, abdomen, everywhere, right? And again, similarly, the lesions can become healed, or they can be latent, right? Anytime you don't follow, just stop me, right? Now, if the child has very poor immunity, then these lesions, the caseation increases in size. The lymph nodes also increase in size. They cause pressure on the airways. They cause pneumonias. They can cause collapse of the lung. Means the air in the lung gets absorbed, and the lung collapses. Or if there is a very poor immunity, then there is massive hematogenous dissemination which happens in the liver, the spleen, the brain. So it's known as miliary tuberculosis, right? So whenever there are lesions across more than 2 organs, it's known as disseminated tuberculosis, and these occur classically as millet seed granulomas, millet seed sized granulomas, which are known as miliary tuberculosis. Right? So a person, the child, or this can also occur in an adult. We have seen people having as an adult primary complex also, who have been recently infected. But yeah, so there will be people coming with CNS tuberculosis, or gastrointestinal tuberculosis, apart from having lung tuberculosis. So that is as far as the progressive primary tuberculosis is concerned. Now, as we saw in the earlier slides, the chances of people, the risk rather of people developing active tuberculosis. So these latent lesions, if the person develops any of those earlier named conditions, right, then there is reactivation, which occurs in any of the sites where the organisms have lodged. Normally, it occurs in the lungs. So this reactivation, and again, if the person is exposed to tuberculosis, and if he acquires an infection a fresh infection from the environment, then also he suffers, and his immunity is low, he suffers from what is known as secondary tuberculosis. So there, the most common form is the pulmonary tuberculosis. Around 80% of people with secondary tuberculosis have pulmonary tuberculosis. So there again, there is this cavitation, there's caseation happening over there. Then depending on the site where the immunity is affected, you can either also get extrapulmonary tuberculosis. Around 4 to 5% people have extrapulmonary tuberculosis. So this is just an example of caseation in the kidney. So this is a progressive secondary tuberculosis. Also can happen, especially in cases of uncontrolled diabetes, severely. Of course, nowadays we don't see people with HIV are already on antiretroviral therapy, so their immunity is improved. But though in the earlier days we used to see massive hematogenous dissemination, again, which could lead to miliary tuberculosis. If you see the timeline at the lower end of the graph, so the earlier situation occurs within weeks, but the latter situation occurs in the year's time. So the natural history of tuberculosis from the point of infection to the development of disease is around 1.5 to 2 years. So a person to develop secondary tuberculosis would have been infected 2 years ago uh, to have developed this sort of tuberculosis. Now I'll halt here if there are any questions, because I expect many questions, and no questions. So can we move forward?
Yes.
Oh, I'm not audible.
Yes, please.
Yeah.
You're audible. Yes.
Okay. So yeah, so the common sites where, as we have seen, where the tuberculous disease can occur, the most commonly occur in the lungs. Pleura are the coverings of the lung, which is the next common. However, they are considered as extrapulmonary tuberculosis. Central nervous system, the lymphatic system, the lymph nodes, the cervical swellings, the axillary swellings. The lymph nodes also occur in the chest, as we've seen in the earlier diagram. So that's lymphatic system. Then the genitourinary system, bones and joints, and then disseminated, which occurring everywhere. So in short, wherever there is blood circulation, there can be tuberculosis. And uh, just to tell you that only the hair and the nails are not affected by tuberculosis. So tuberculosis can occur right from the skin right up to the brain. Okay. And, yeah. So how does one evaluate? If this is clear to everybody, then we'll go on to evaluation of a patient of tuberculosis. Yeah. So how does one evaluate for tuberculosis? So we have a clinical evaluation, of bacteriological or a pathological evaluation, and a radiological evaluation. So in clinical, we go to the medical history and do a physical examination after having a presumptive suspicion of tuberculosis. Then we subject the person to bacteriological or pathological examination and or radiology. So, taking the medical history, we look at the symptoms of the disease, right? So these are very important. They will come to later. What are the symptoms of tuberculosis, and with respect to TB itself, and with respect to its affecting the various organs. History of TB exposure, infection, or disease is very important, because that will tell us in these present days, because we have a lot of tuberculosis in the community. So type of tuberculosis which a person may have acquired, either drug susceptible or drug resistant, could be postulated from the history of TB exposure, the index person whose background we need to understand. The past history of TB treatment, whether the person uh, has been diagnosed in the past with tuberculosis and what treatment he has been taking over the period of diagnosis, and whether there are any demographic risk factors for tuberculosis, or whether there are any medical conditions that increase the risk for tuberculosis disease. All the medical conditions that which we described earlier, one needs to ask for when they are looking for a tuberculosis diagnosis. So the classic symptoms of TB, so we can divide the symptoms of TB into two. One is the constitutional symptoms, the symptoms which occur due to the presence of the TB bacillus in the body. So that's a reaction of the body to the presence of the bacillus. So the commonest is fever. Fever can be the classical textbook type fever is evening rise, low grade fever. But we can get very high grade fever. We can get acute onset fever. We can get intermittent fever also. So, but the classical type of fever which has been described in the textbooks is mild low-grade fever. Sometimes people may not even have fever. Fever can occur with chills, and there would be night sweats. There would be appetite loss, which can gradually lead to weight loss, and then the weight loss leads to easy fatiguability. So these are supposedly the cardinal symptoms, what we normally used to call them for suspicion of tuberculosis. And going to the symptoms of pulmonary tuberculosis, the common symptom is prolonged productive cough for the duration of more than 2 weeks, which is not responding to any broad spectrum antibiotics, or which is not due to any other associated conditions like asthma, COPD, those other conditions. There can be chest pain depending on the site of disease. There can be hemoptysis. Hemoptysis is presence of blood in the sputum. It can be just a few drops, or it can be a massive hemoptysis, which can lead to drowning also suddenly. And depending on the extent of the lung which is involved, there can be breathlessness. And there can be even breathlessness even in the minor disease. A small lung portion involved due to an allergic reaction also, due to the presence of the organism. So this is what is known as non-specific asthma, which can also occur due to tuberculosis. Symptoms of extrapulmonary tuberculosis depend on the site or the organ involved. Normally, commonly seen are the lymph nodes. If you see people having cervical lymph nodes, swelling in the neck region, and this is the commonest form of tuberculosis. If there is abdominal tuberculosis, it can present with, there are some 5 or 6 varieties of abdominal tuberculosis. It can present with sort of pain in the abdomen if there is lymph nodes. It can present with distension of abdomen if there is ascites, that is fluid in the peritoneal cavity. It can also occur as a surgical emergency if there is blockage in the intestine. The ileocecal region, which is the small intestine junction with the large intestine, gets commonly affected, and that gets blocked. So a person has symptoms of intestinal obstruction. It can come with vomiting and constipation. So these are some of the common abdominal tuberculosis symptoms. Then if it is bones and joints, depending on the area involved, if it is a joints, then there will be swelling and pain and affection of the movement. Other bones, there will be again swelling and swelling over the skin. So painful swellings. Genitourinary tuberculosis. Genital tuberculosis normally usually in women present as infertility. Even in men, we have seen infertility as a common presentation of tuberculosis. Headaches, different types of headaches are common with neurological, that is the central nervous system type of tuberculosis. And of course, depending on if the eye is involved and there is the redness of the eye, loss of vision, so many other things. In eye also, there are some 8 to 9 varieties of tuberculosis. Skin also, there are around 8 to 9 varieties of skin tuberculosis which can occur. Unfortunately, I have not brought any of those clinical pictures for, otherwise people would faint on this lecture. Right, so there are various types of presentations for extrapulmonary, and we are lucky that only 5% of tuberculosis is around extrapulmonary, but it's increasing of late. So yeah, coming to the diagnosis. Any questions on the previous section? Or you want to hold the questions till the end? Okay, doesn't matter. Yeah. So coming to the diagnosis of tuberculosis is basically demonstration of MTB or acid-fast bacilli in any of these sites. So as far as pulmonary tuberculosis is concerned, the first examination, which of course now has been relegated to the past, is the sputum smear examination. As I had mentioned, this is the identification of acid-fast bacilli on a sputum smear stain with Zeal-Nielsen stain. Either you do a hot stain or a cold stain, and identify the organisms which I had shown you earlier. Nowadays, we have the newer technique, the molecular diagnostic techniques, the cartridge-based nucleic acid amplification test, which is Gene Expert. Of course, these are trade names, Gene Expert and TrueNat, which give us a diagnosis of tuberculosis supposedly within 2 hours of the sample being acquired. It's a PCR-based test, and I think most of the people over here know the techniques better than I do. Then the culture and the drug susceptibility testing. Culture is still the gold standard of diagnosing active tuberculosis. And of course, based on the culture results, then we subject the sample to drug susceptibility testing for reasons which we will see later on. And the newer tests are the gene-based tests, the whole genome sequencing, which is still in the infancy stage in India. However, in the Western countries, I think especially in the European countries, they are using whole genome sequencing as the basis of their diagnosis. And the second is the diagnosis of tuberculosis, which is a sort of a surrogate diagnosis. So reaction of the presence of Mycobacterium or tuberculosis in the tissue and where the infection is present. So that's the other way of looking at the diagnosis of tuberculosis. This is especially in cases of extrapulmonary tuberculosis. Of course, there are a whole other tests like the urinary lamb and the other tests which I have not mentioned over here. And so this is a very busy slide, but this is how the diagnostic algorithm goes. So a person, so this is the latest algorithm. So a person either having suspected to a presumptive, we no longer use these terminologies of suspects and default, where we use a person having presumptive TB or a person who has been diagnosed with TB is subjected to a CBNAT test, and a CBNAT test will give us either the presence, both the presence of or absence of the Mycobacterium tuberculosis and its susceptibility to whether it is susceptible or rather resistant to rifampicin or not. So a person whose sputum shows CBNAT positive that is MTB detected and does not show any resistance to rifampicin, that the second sample is subjected to the first line probe assay and to detect presence of INH resistance or INH susceptibility. A person whose CBNAT shows the presence of MTB and detects rifampicin resistance, that second sample is subjected to second line LPA, second line drugs. So basically so far what is available is fluoroquinolones and second line injectables. There are newer tests which are being developed to test for other drugs also. So then it is subclassified as fluoroquinolone and second line injectable sensitive, or fluoroquinolone and or second line injectables resistant. And we'll come to the classification of tuberculosis in a later slide. So this is clear, we can move forward. As far as diagnosis of extrapulmonary tuberculosis is concerned, we normally do what is known as a fine needle aspiration cytology, which is easier to perform. There's also a true cut biopsy, which we can do for lymph nodes, and or you can do a biopsy. Now, these tests are followed by, again, CBNAT and histopathology, which show changes suggestive of tuberculosis in the tissue. Now, radiology is performed to confirm what you call, not a, it's a presumptive diagnosis. It does not confirm that a person is having tuberculosis, but there are certain shadows or presentations which are very sort of characteristic of tuberculosis in the various organs. So if we can do an ultrasonography, you can do CT scans, and you can do MRIs to come to the diagnosis of extrapulmonary tuberculosis. However, whenever these tests are performed, it is good to do a bacteriological test through either a CT-guided biopsy or some other procedure. I will not cover pediatric cases, but then two tests which can be done to diagnose tuberculosis in children is the tuberculin skin test and the interferon gamma release assay. Diagnosis of tuberculosis in children is very difficult, and it's a sort of we need to look at the complete clinical presentation, the family history of tuberculosis, exposure to tuberculosis, then identify the radiological examination, do a, as far as possible, if it is possible, then you do a gastric lavage to identify MTB. Surrogate markers are like tuberculin skin test and the interferon gamma release assay. That's as far as the tests in pediatric cases are concerned. Chest X-rays are used very commonly as a screening tool. If the person, so now what happens in cases, active case finding scenarios, we normally go by symptom screening, the first 5 cardinal symptoms that we saw, along with a chest X-ray. If both these are suggestive of tuberculosis, then we go in for the specific sputum-based test. So they're used as screening test, and there's no chest X-ray pattern, which is absolutely typical of tuberculosis. And it is also seen that 10 to 15% of culture-positive TB patients do not get diagnosed by X-ray, because one X-ray is a sort of a 2-dimensional picture, and we may not get the complete picture of what is lying behind the heart or behind the lymph nodes. So in that case, a CT scan would have been a better mode of diagnosis. But it's a very good screening tool. It is also used for monitoring the progression of disease and along with the treatment schedules.
Sir, may I
Yeah.
ask you a question here?
Yeah.
Will you be able to see lymph node enlargements, lymph node TB through X-rays?
On chest X-rays?
Yeah.
Yeah, if it is a big lymph node, and you'll be able to see it. But small lymph nodes will not be able to see. And for that, you need CT scans.
By small, is there a size limitation?
There is no size. It depends on the, see, it is like, what the mind does not know, the eye will not see, right? So it all goes with experience as to, there are people who have, seen the minutest of lymph nodes on chest X-rays, which have then been confirmed by CT scans. But sometimes people miss large lymph nodes also. You will see it very commonly in clinical practice. Yeah.
Thanks.
Can I ask one question?
Yeah.
Vidula, your something is on the side.
Yeah. Can you hear me now?
Yeah.
Yeah. So, sir, can you explain how X-rays are used for monitoring treatment?
So I don't have any X-ray pictures with me, but we take a baseline X-ray when the diagnosis is made, and then we take serial pictures, not very serially, but say at the end of the intensive phase and at the end of treatment, and see how the lesions appear on the X-ray, and that's how they tell us. So it's the softness of the shadow, the hardness of the shadow, the extent of the lung involvement, which would appear to shrink on repeat X-rays. So these are the ways you can use in monitoring treatment. As again I said, it is not very specific. It's a very, although it's very sensitive. But you don't see X-rays in isolation. You have to see it along with the clinical picture, whether the patient's symptoms are reducing, whether the bacteriology is improving. The sputum conversion is happening. Right? So we see all the three things together. Never see an X-ray in isolation.
Right. Thank you.
And do you see these changes even within 15 days of treatment?
No,
Usually
no.
15 days, there's a significant change.
Oh, then you have to relook at your diagnosis. If it is because rifampicin is a very broad spectrum antibiotic, right? It takes care of gram-positive, gram-negative, and it's also an antifungal antibiotic. So you need to, if it is regressing in 15 days, then you have to rethink unless it is proved bacteriologically. Right. The only thing which will appear and disappear in 24 hours is your pleural effusion, because it can sometimes be due to hypersensitivity reaction to your tuberculosis proteins. So coming to the classification of tuberculosis, this is my way of looking at it. So as we have seen, it can be classified according to the stage of the disease. It can be primary childhood tuberculosis, post-primary or secondary or adult tuberculosis. And you can classify according to the site of disease, whether it is pulmonary TB, PTB, it can be either sputum positive or sputum negative. That's a radiological diagnosis, or an extrapulmonary. Then the other classification, which is more appropriate for the program and for management, is previous treatment of tuberculosis. So if the person has not taken any treatment in the past or less than 1 month rifampicin containing treatment, then he is classified as a new case. A relapse, I forgot to mention the reinfection, but a relapse or a reinfection is a person who has had tuberculosis in the past, has been cured of that, and he's got a new episode of tuberculosis. That is known as a relapse or a reinfection. A treatment after default is obvious because a person who has stopped treatment for more than 2 months after starting treatment and discontinued it. So when we start treatment, we classify him as treatment after default. Treatment after failure is a person who has been on regular treatment, but his sputum is not converted. And also, the CBNAT or the cultures show that he is suffering from drug susceptible tuberculosis. Then he is put on the same drug susceptible regimen, TB regimen, or if he is found to be having drug resistance, then appropriate treatment has to be. And others with anything that does not fit into this above 4 is classified as others. Right? And then the recent classification which we now follow is according to drug susceptibility. So either it is drug susceptible or drug resistant. It can be either MDR, XDR, TB, etc. And on request of Kalpana, I have just briefly mentioned the newer definitions. So DSTB is when MTB is susceptible to all first-line medicines, including rifampicin. DRTB is drug-resistant tuberculosis when MTB is resistant to any first-line or second-line drugs. RR is resistant to rifampicin. Then there can be H monoresistant tuberculosis. Again, there is a subclassification in this, whether it is CATG, INHA, singly or both. Then there is polyresistant tuberculosis, resistant to more than one drug, which is not rifampicin. Then there is MDR-TB, which is resistant to rifampicin and INH. And the latest WHO guidelines has reclassified the pre-XDR tuberculosis as MDR plus resistant to fluoroquinolone. Initially, it was MDR plus resistant to either fluoroquinolone or a second-line injectable, but now it is resistant to fluoroquinolone. And XDR tuberculosis is MDR tuberculosis plus resistant to any of the group A medicine. We'll see what the group A medicines are at a later slide. Okay. So this is the latest classification. So then moving on, if all that is clear, then we move on to treatment of TB disease. Yeah. So the aims of anti-TB treatment, one is basically to cure the patient, to prevent death from active TB or its late effects, to prevent relapse of TB, and to decrease transmission of TB to others. Right. So these are the primary aims of TB treatment. The earlier you start treatment, the better it is. It will prevent deaths, because the later you start, there is extensive lesion and patients may get cured of tuberculosis, but its late effects like post-TB sequelae, COPDs, and other conditions which can develop with it can cause mortality. So we have to prevent that. Prevent relapse of tuberculosis. That's also one of the main aim. And of course, treat early and decrease transmission of TB to others so that the pool of infectiousness is reduced and the transmission is reduced in the community. So these are the aims of anti-TB treatment. Basic principles of treatment are to provide the safest, most effective therapy and in the shortest possible time. Initially, when the first anti-TB drugs were identified, the treatment used to be 1.5 years, and with the advent of rifampicin and then pyrazinamide, so the treatment schedule got shortened to 6 months, and now we are looking at treatment shortening to say around 4 months. Of course, I'm skeptical about that, but still we need to wait and watch. So provide the safest. It should be safe. There should be no adverse drug reaction. It should be short so that patients continue with the treatment. And of course, as we have seen, it should be most effective because it should sterilize the lesion of all the TB germs. Normally, we have to give multiple drugs to which the organisms are susceptible, because if you give drugs singly, then there are chances of developing resistance, which was seen in the earlier stages when the drug development was very slow. and never add a single drug to a failing regimen. So we always remove 2 drugs and add 2 more drugs so that amplification does not occur. And of course, ensure adherence to therapy. So that's the backbone of TB control. So adherence has to be at least 90 to 95%, if not 80%, so that there are chances of good cure. So anti-TB treatment regimen is a combination of drugs, as I mentioned, and it is given in 2 phases. There's an initial intensive phase, which will achieve the maximum kill and try to sterilize the lesions, or at least kill most of the bacilli, and a continuation phase which will maintain that throughout there, so that the remaining bacilli get killed by both the drugs as well as the body's immunity. So that's the anti-TB treatment regimen. So these are some of the agents which we normally use. First line agents are isoniazid, rifampicin, pyrazinamide, and ethambutol. Streptomycin we no longer use nowadays as it has been found to have a lot of renal toxicity and auditory nerve involvement. The second line agents which were and are being used are injectables like kanamycin, amikacin, capreomycin. So the first 2 are the aminoglycoside groups. And you have the fluoroquinolones, which are the levofloxacin, moxifloxacin. You have ethionamide, you have cycloserine, para-aminosalicylic acid. So these are the para-aminosalicylic acid is one of the very early drugs, which is still being used as second line drug. Linezolid and clofazimine. Clofazimine was also commonly used for leprosy. And now we have the newer drugs, the bedaquiline, delaminid, and pretomanid. So these are the second line drugs which are now being used for managing tuberculosis. So this is the latest grouping of anti-TB drugs, the second line drugs, which are used for designing longer MDR-TB regimen. So if you see, the group A includes levofloxacin or moxifloxacin, bedaquiline, and linezolid. So we have to include all 3. You can either use levofloxacin or moxifloxacin depending on again whether the fluoroquinolone resistance is there or not, and whether moxifloxacin in high doses is susceptible. So that's what we use. So we use all 3 the group A drugs, and then the group B drugs, we add 1 more drug from here, that is either clofazimine, cycloserine. Cycloserine is also available as steridazole, which is a lesser toxic drug. And then in the group C, we have ethambutol, delaminid, pyrazinamide, and imipenem, celeste, and of course meropenem. These are injectables and which have to be given continuously for 6 months and through a port. So it's very difficult because the port itself is very expensive to insert, and it has to be given twice or thrice a day. Amikacin can also be used, ethionamide or prothionamide, and para-aminosalicylic acid is the last in the group. So there are certain guidelines is saying which to substitute when, if there are either certain drugs which are to which the organisms are resistant, or a person may not tolerate, as all these drugs are highly toxic drugs, and they need to be monitored very meticulously. I have not given you a full list of hold on. Do you want to go through this slide? I think I should better avoid it because the next slide tells us everything about it. So these are the treatment regimens. So for DSTB, we still use the 2 months of INH, rifampicin, pyrazinamide, and ethambutol, and continued by 4 months of INH, rifampicin, and ethambutol. 6 months of total treatment. 6 months of total treatment. Especially for pulmonary tuberculosis, which can be extended for skeletal tuberculosis, that's bone and joint, CNS tuberculosis, abdomen, and genitourinary treatment. Genitourinary tract tuberculosis. For skeletal, we give 9 months, CNS around 1 year, and both for abdomen and GUT, we give for 9 months. For H monoresistance or polyresistance without any rifampicin resistance, we give 6 to 9 months of treatment with levofloxacin, rifampicin, pyrazinamide, and ethambutol. Formerly, an injectable was also being given, but because of the side effects due to the injections, it has been removed from this regimen. Then the shorter DRTB regimen is 6 months of bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, and high-dose INH and ethionamide, followed by 5 months of levofloxacin, clofazimine, pyrazinamide, and ethambutol. Again, it all depends on the drug susceptibility testing, which one has to carefully look for. But the commonly used, especially in Mumbai, we are using longer DRTB regimen, which is an 18 to 20 month bedaquiline based regimen. So this is known as an all oral bedaquiline longer regimen. So bedaquiline should be given for 6 months, but in certain cases it can be given for longer periods, along with levofloxacin if it is susceptible, or moxifloxacin, cycloserine, clofazimine, and linezolid. So these are the 5 drugs which we use. And after discontinuing bedaquiline, the remaining drugs will go on. And sometimes we have to reduce the dose of linezolid because of severe side effects of peripheral neuropathy. Or sometimes even cycloserine has to be discontinued because of CNS and psychological or psychiatric disturbances. So this in short is the brief of the previous slide, which was too busy, and it would have confused, even it confuses me, so it would have confused you immensely. So,
Sir, is the drug
Yeah.
sensitive continuous phase is only rifampicin isoniazid, right? Even ethambutol is given.
pardon, no, ethambutol drug susceptibility is not done. Pyrazinamide is done. It's a phenotypic drug susceptibility.
No. For the continuous phase, isn't it just 2 drugs, rifampicin and isoniazid?
Which DSTB?
The DSTB, yeah.
No, there are 3 drugs. No, INH, rifampicin, and ethambutol.
Okay. Ethambutol is given. I thought it's
Is given, yeah. So formally, the ethambutol was not given, but sometimes what happens is INH resistance is some in the periphery and rural areas. It's very difficult to get these results. So that's why they added ethambutol in the continuation phase. So yeah, so this is the adverse drug reactions. I haven't given you the full list. So isoniazid, the commonest side effect is peripheral neuropathy, hepatitis. Of course, it also has sort of psychosis as one of the side effects. Rifampicin, the most common is gastrointestinal. All these drugs have gastrointestinal side effects. They give rise to nausea, vomiting in the initial phases of treatment. So first 15-20 days, the person gets gastrointestinal side effects. Hepatitis is common, so one has to monitor the liver function tests. And of course, rifampicin reduces the effectiveness of oral contraceptive pills, anticoagulants, and many steroids and many other drugs because of activation of the hepatic enzymes. Pyrazinamide, what we have seen commonly is joint pains, arthritis, and arthralgia because of increased uric acid levels. Hepatitis is seen more in the Western countries. We haven't seen much hepatitis with pyrazinamide. But ethambutol is a dangerous drug because once the optic neuritis sets in, then it is irreversible, and one has to be monitoring it very well. Because and of course counseling of the patients, because the first vision to go as color vision, and then the field of vision, and then the visual acuity. So by the time the person, the visual acuity reduces, a lot of damage is already done, and it is not reversible. So that has to be. And of course, second line TB drugs. The newer drugs have a lot of cardiotoxicity. Linezolid has a lot of peripheral neuropathy, and it has myelosuppressive action also. It affects the teeth, it affects the ears, it affects the eyes. Then cycloserine, of course, is it precipitates seizures. It has suicidal tendencies, like schizophrenia-like symptoms. It also can give rise to depression. Yeah, of course, clofazimine gives very bad dark discoloration to the skin, which sometimes it's permanent, but it takes years, ages for it to come back to the normal. So these are the, and levofloxacin, of course, moxifloxacin, cardiac side effects, as well as tendinitis and severe pains can occur with fluoroquine. Of course, second line injectables have been given up because of their auditory nerve involvement, and sometimes renal toxicities can happen. So yeah, just because Shilpa wanted me to, briefly touch on adherence, I'm not a very good at this, but this is what the program has done. So directly observed treatment was first when the RNTCP was started. Then directly observed treatment was the aim for giving tuberculosis treatment. So patient had to come to the center and consume the drugs in front of the healthcare provider every alternate day. But with the daily treatment, now the new ICT-based adherence technology, that's a 99 dot, a person gives a missed call to the number which is present behind this, blister, and it gets registered on the dashboard so that the health worker can know that the patient has at least opened the blister. And then there is this merm pill box, and again you open the box, a signal is sent to the district TB center. But both these things, they just tell you that the patient has opened the boxes or opened the blister, but whether they have consumed it, it's not very certain. So in Western countries, they have what is known as the video dots. So they ask the patient to, put on their video whilst consuming medicines, and that is recorded by the health worker. So, and there's this one, if someone must have heard of ASHA, they have this system of biometric, where whenever the patient comes to their center. So they have a public-private partnership where they establish centers and across 600 sites in globally. And they have a biometric system where the patient comes and sort of consumes the drugs in front of the healthcare worker, and it's recorded. So these are certain adherence technologies, but I think we need to have someone else to also talk about this. And so lastly, what are the treatment outcomes? We have a cure. A cure is a person who has been detected with a positive sputum, either by smear or by any other molecular diagnostic test, who at the end of 6 months or the end of adequate therapy has a sputum result which shows negative, either culture or smear, then he's labeled as cured. And as treatment completed, the person either does not have an end of treatment sputum report, or he has a sputum negative initial report. And both these, for the program, these constitute together the treatment success. Failure is a patient who has taken continuous regular treatment and whose sputum does not convert at 2 months. Formerly it was 5 months, now it is 2 months, and then it is considered as a failure. Death due to any cause, in a person who's on treatment is defined as that. Loss to follow-up, a person who has not taken treatment for more than 2 months after starting treatment is labeled as loss to follow-up. Transferred out is, of course, to any other facility where he has migrated out. And not evaluated is patients who could not be evaluated for any other reason. So these are labeled as not evaluated. This is for the NICSHA entries.
Sir, is default not a formal
Pardon?
default? on
Default.
treatment?
Default. To give you a background, the WHO has recommended good language for patients. You know, the patient-centric approach. Now, like TB suspects, they don't call them TB suspects. They call it presumptive tuberculosis, right? And the default is actually given up. So now they call it loss to follow-up. Right. So loss to follow-up is default.
But is it seen in the field level? Are people stopped using that?
Yes. That we see around anywhere ranging from 15 to 20%, and depending on what type of treatment. If you see MDR TB treatment, a lot of people have defaulted, and that's why you see the success rates ranging only between 56 to maybe 60-65%. And so then the last topic that we need to look at is prevention. So prevention of transmission. So FAST is Dr. Ed Nardell. Of course, many of us are familiar with him. He developed this acronym FAST: find early, diagnose properly, and treat early. So this is the background of treatment. Then, of course, airborne infection control, administrative controls, and environmental controls, personal protection. These play a big role. So we can have a separate lecture on AIC also. Then treatment of TB infection. Now that's the latest thing which is happening because we need to end tuberculosis by 2025 in India and 2035 globally. So primary prevention, all contacts below 6 years, eligible people living with HIV, at-risk groups will need primary prevention. So there are certain regimens. 3HP is 3 months of weekly isoniazid and rifampicin therapy, or 6 months of DDINH, or 6 months of DDINH and rifampicin. So this is for drug-susceptible TB contacts. And for DRTB contacts, there are no recommendations at present. Fluoroquinolones are being considered. And in Russia, what I heard last time when we were in Dubai, the Dr. Mistry, was that they were planning to have preventive, TB infection treatment with bedaquiline. I haven't heard what is happening. And then, of course, vaccines are under development. The BCG vaccine that is currently available is 60% effective. It reduces the severe types of tuberculosis amongst children. However, it does not prevent adult type of tuberculosis. So pre-exposure vaccines, post-exposure vaccines to target dormant MTB and prevent the activation, especially in people who are latently infected. And a therapeutic vaccine like MVAC and VT to shorten treatment duration, time to sputum conversion, and improve cure rates in DRT. So these are the prevention. So there will be experts who can deliver lectures on this also. I think that brings us to the end of my today's talk. I put a question and answer, but I think most of it has been dealt with during the talk. If you have any questions, then I'm there.
So Dr. Dolakia, I have one question.
Yeah.
So is CBNAT suggested for all EPTB cases?
See, the diagnostic algorithm says CBNAT has to be done for diagnosis of tuberculosis. Now, all EPTB cases, it will be difficult to do CBNAT, because most of the EPTB cases, they are diagnosed clinically and through radiology. Okay, patients do not consent for invasive procedures, because sometimes they have to be CT guided, sometimes they have to be operative. So it may not be possible. It's possible only in case of pleural effusions and peripheral lymph nodes, where fine needle aspiration cytology can be done. And the other thing is that see, all these extrapulmonary TB cases go to different specialists like orthopedicians and gynecologists and all. They are not very well versed with diagnosis of TB. So once they operate or they diagnose, then they don't like to repeat it. And many times, even after telling them, okay, whenever you are removing a sort of a tissue, you subject it to both histopathology and mycobacteriology. Whichever way, either you do CBNAT or you put it directly for MGIT culture. But see, most of the times they collect in formalin and then the tissue is lost. So these are various practical issues which we come across.
And
Also the sensitivity, also the sensitivity of this is quite different for EPTB samples, right? It's not very
it's not very. So now we have ultra and all those things for CSF, but I don't know what their results are.
Right. Thank you.
If you formalin fixed tissues, can't AFB be dead?
Formalin, AFB will not be affected, but when you want to subject it to culture,
culture you can't, but maybe AFB staining or something can.
That can be done. Yeah, but then see, the request has to be there. Most of these are from the private sector, and even in public sector, we find it difficult, to convince people to do these tests. Shilpa has a question, I think. Yeah, Shilpa. Yeah, Shilpa, go ahead.
Just 1 minute.
I can't hear you.
Just 1 minute.
So I think some mic issues. Meanwhile, I think Vidula has put up saying if Gene Expert and TrueNut are two different tests. I think Faizad has answered.
Faizad has answered it. Yeah.
Hello?
Yeah.
Yeah, I had 3 questions. One was about the primary prevention drug treatment, the treatment regimen.
Yes.
So has it already started? I mean, is it given in the public sector for all primary contacts?
Yes. It is part of the, actually it is part of the RNTCP. All contacts have to be examined, and then if they are not found to be having active TB, they have to be given primary chemoprophylaxis. So the risk groups are the children below 6 years and PLHIV. And they extended it to diabetics who are not under control, but that is not being very strictly followed.
Okay. But for other high risk, it is already expected that they should be on this prophylaxis.
It is expected, but it is not implemented.
Yeah. Okay. Okay. So my next question was about diabetes. Like for TB patients who have diabetes, what is the difference for them right from detection to monitoring to treatment regimen? So where all does it make difference?
There is no difference. The problem is their diabetes has to be strictly controlled. If the diabetes is not strictly controlled, their response to TB treatment is very poor, and their relapses are also very high. So I didn't show it. Yeah. So the relapses occur within no time, within 6 months, actually.
Okay. It's a relapse within 6 months for a diabetic.
Yeah, relapse within 6 months. Yeah.
Okay. Okay. And my third thing was about the pregnant women.
Yeah.
So what are the differences in terms of whether it makes any difference from diagnosis to treatment outcome for a pregnant woman with TB? What are the differences there?
The diagnosis, as far as the X-ray is concerned, during the first trimester of pregnancy, we don't do X-rays. Right? Of course, now there are safe shields and all which we subject. As far as the drugs are concerned, now we don't use streptomycin. So the streptomycin also was not advised during the first trimester of pregnancy because of fetal abnormalities which occurred. But
Okay.
other drugs are safe. Other drugs are safe.
Okay.
And second line drugs, mostly they are safe. And we try and, when we start treatment, as per the pre-treatment evaluation, we do a urine and pregnancy test. And the person is found to be pregnant. And within the period of medical termination of pregnancy, we counsel the patient for medical termination. And yeah, so that's what we do, because we don't know so far what are the long-term side effects of these medications, especially the newer ones, the bedaquiline, the delamidine, and tetramethaine.
Okay, I lost a few words, but just wanted to reconfirm. So MTP is not a preferred choice, or is it recommended, or what is it for the pregnant?
It's the patient's choice, basically. MTP within the first, legal period of 24 weeks, 3 months. Right?
Yeah.
So that is the patient's choice. Sometimes the patients wish that we continue, and then we have to counsel them for good adherence, good nutrition, and of course caution them that there could be fetal abnormalities occurring if side effects, especially for second line drugs. First line drugs, normally they tolerate very well.
Okay. Thank you.
Okay. Yes, 3 participants. Who are these? Kamal Khan. Yeah, Vidula. Hello. Yes. Hello.
Hello.
Yes.
Yeah, hello, sir.
Yeah, Boli.
My question is just similar to Shilpa's question, but the population is different. It's about the children or pediatric TB. So, is it the same treatment protocol or is also the diagnostic?
Yeah, so the treatment protocol doesn't differ. It's the dosages which are reduced. The doses are per kilogram body weight.
Okay, now what about the diagnostic?
Diagnostic test, sometimes it's difficult for children to bring out sputum. So then you have to do what is known as a gastric lavage. Right? And of course, our foundation has also been trying masks, and then I hope they will try also stool examination to identify TB bacilli. And yeah, all these are but experimental. So the time and tested is either gastric lavage, or if the parents agree, then you do a fiber optic bronchoscopy, a bronchoalveolar lavage, and get the test done. Otherwise, treatment is through clinical suspicion, clinical diagnosis.
Yeah, there is no radiological or other like the
Radiological, of course, yeah, X-rays are there. You can do a CT scan, you can do an ultrasonography, you can do an FNAC if there is a gland. So those things are there. Yeah, same things.
Okay, thank you.
Okay. I think Vidula had a question where she's gone.
No, it was by mistake.
Okay. Okay, so then I think, yeah, thank you everyone. Yeah, someone else raised.
Yeah, hello, sir.
Hello.
I just want to confirm, like, do we have any kind of test or any kind of any kind of procedure to detect the MDR-TB earlier at the time of infection?
Infection? No. Even detecting tuberculosis plain infection is sometimes difficult. For MDR-TB, no.
So any of the new the trainees would like to ask a question? I think that's it, no, sir. So we can-
Okay. Okay, thank you then. Yeah,
Thank you, sir.
thank you. Thank you.
Thank you very much, sir.
Thank you, sir.
Thank you. Thank you.
Thank you.